Merci beaucoup. Thank you so much for joining us. This has been I guess, sort of Apple versus, Microsoft transition day. We have a special, artificial intelligence transformation here. And so thanks very much for joining us on this work in terms of a weekly research conference. And we are absolutely delighted that we'll have Dr. Hassan Mir as our guest speaker. But before that, just like acknowledge is unceded traditional territory of the Algonquin Anishinaabe and the people of the Algonquin Anishinaabe Nation. We recognize First Nations, Inuit, and Métis, and peoples from all nations across Canada. We acknowledge the traditional knowledge keepers, both young and old. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation and build resilience and health together. And indeed, today's talk is particularly relevant from that point of view, and it's relevant, I think, for all of us. And so this is a hybrid event. So for those who are joining us, please use your technology, and if you have any questions, use the Q&A feature, and but use the chat feature if you have technical issues. And so just to remember that for those of us able to pose the questions directly, please use the microphone at the end of the presentation. And then for those who are joining us online, use the Q&A feature, and we will actually answer the questions in turn. So we're delighted to have Dr. Hassan Mir with us today. He's a clinician investigator, cardiologist in division of cardiology here at the Heart Institute, assistant professor of medicine at the Faculty of Medicine, University of Ottawa. And his research really focused on the cardiovascular prevention aspect, particularly with a focus on smoking, vaping research, and also digital health, some of the most important aspect in terms of growth in the area of healthcare today. And Dr. Mir performed his undergrad studies at the McMaster MD degree from Western University and subsequently completed internal medicine and cardiology training at McMaster University, and where he served as chief resident and subsequent fellowship in advanced echo and prevention at University of Toronto. And but Dr. Mir never stops, to accumulate more credentials. And even after he's coming on staff, he has continued to build his foundational tools to conduct excellence in clinical research. Past couple of years, completed a Master of Health Informatics at the University of Toronto and Master of Public Health at Harvard University. And he's leading several important randomized control trials, and in terms of implementation science, implementation projects related to smoking and vaping cessation. And I think this is really exciting, in terms of area where he's doing the research, whether on the digital health or on smoking cessation, where he's accumulating objective evidence, that can actually change guidelines and change practice. And that's super important for these areas of endeavor. And he has a grant funding from multiple peer-reviewed agencies. And I think most recently, really a major grant from Canadian Cancer Society, more than $500,000, plus many other, major projects. So he's been super successful. And he's been recognized for his research as well. And so not only he serves as the chair of smoking cessation here at the Heart Institute, and he also the co-chair of the virtual care heart team and director of the hypertension program. And he's also executive member of the Health Promotion Committee of Canadian Society of Internal Medicine, executive member of American College of Physicians, Ontario chapter, with a particularly focus on those areas as well. He serves as chair of the Health Canada Standards Council of Canada Technical Committee in terms of developing national standards of smoking cessation, member of Ontario Health Cancer Care Ontario Smoking Cessation Advisory Committee. And it's been recognized previously by Ontario Medical Association in terms of Resident Achievement Award, Royal College of Physician Surgeons with the Kristen Sieverts Leadership Award, Canadian Society of Internal Medicine with the Huey Lee Health Promotion Award, and more recently also recognized the American College of Physicians, the Ontario Chapter Laureate, and the American College of Cardiology Leadership Forum Award, and so on. And so it's a real delight to have Hassan today to give us a really interesting talk. It's on breaking free and innovation in smoking and vaping cessation research. Fantastic. So welcome.
Thank you so much for that really too kind an introduction. And I only wish I could take Peter home to my wife and just have him speak for a little bit. And also may all of my grant reviewers be like Peter Liu. You know, I pray for that. So thank you so much for that. And a lot of the things that we'll talk about today will also be discussed in the kind introduction that was provided. And it's truly my pleasure and honor to be presenting to you. A couple of, I'm going to initially start off with a disclosure. So the first one, as Dr. Liu kind of alluded to, I make all of my presentations on MacBook. And since we moved that onto this particular computer, the font has kind of gone haywire. So we're assuming that AI has chosen to do its own business at this point. In case you see any errors, I assure you those are not, well, maybe they were, but I mean, I'm going to bank on the fact that actually it was all the computer's fault. So first and foremost there, and what I'm hoping to do today is to discuss a little bit about some of the past, present, and future work that our team is doing within the world of smoking and vaping cessation to highlight some of the leadership that we have, not just locally, but at the international level. All right. So if we can go there. So Dr. Liu kindly did a land acknowledgement. So I would just reiterate that as listed on the sheet. And in terms of disclosures, of course, as mentioned, I don't have any sort of pharmaceutical or industry disclosures or any sort of conflicts. I purposefully try to avoid those, but will just mention that I have received some grant funding. Also, I serve as the chair of the Ottawa Model for Smoking Cessation and the Quit Smoking program locally. In terms of the objectives, what I was hoping to do today is review the evidence for the Ottawa model for smoking cessation that has occurred over decades, review our current smoking and vaping cessation projects, as well as discuss some of our upcoming research and innovations relating to smoking and vaping cessation. Before I do this, though, I want to appropriately recognize the people that make it possible for me to stand here. And the first couple of people, I guess there's three certain people that come right to mind. So the first would be Andrew Pipe and and the second would be Bob Reed, who helped found and develop this model. A lot of the research that I will be presenting was developed and generated and done by them. So I'm obviously very much standing on their shoulders and taking the ball from what has been passed on to me to the next level. And then a couple of other people, specifically Dr. Carrie-Ann Mullen, who's a scientist at the University of Ottawa Heart Institute, who's done a lot of the initial seminal work relating to what I'll be presenting. And then, of course, within our operations team, we've got Mustafa, who's our manager, and wanted to give a shout out. But this wouldn't be possible without this massive team, right? So we have within the OMSC almost 30 staff that work with us that make it possible for us to develop content, to deliver content, to actually implement our programming, to collect data, to partner with sites, collaborate, to evaluate that data, and then subsequently present it. And again, much of what I will be presenting, a lot of these things would not have been possible without the staff here. So it goes without saying that there is an absolutely necessary shout out to the OMSC team. And then within my own research team that we're growing recently with Evian in terms of our research manager, Tanya, who's provided administrative duties. We've got several research coordinators, trainees, including Javad, who's our postdoc, who's in the back there, Emma and Spencer, who are two master's students, as well as several medical students that are coming on and working with us over the summer. Again, these things wouldn't be possible without them. So I did want to appropriately recognize our team relating to that. So getting right into it. So now you're going to see some pretty old looking slides because they are pretty old. And again, I can't blame the grammar or the AI for that. But I think I thought it would be important for us to know where we came from and then what we're doing and then where we want to go. And where we came from, this is one of the first studies that was ever published looking at the Ottawa model for smoking cessation. This is back in 2006. And you'll recognize some names in the authorship list. And what they demonstrated was implementation of the Ottawa model for smoking cessation resulted in a significant, like 15% absolute increase in the rates of smoking cessation. And this was really the foundation that set the ground to say, okay, well, we've got something here that's really special. That wasn't the only place this was evaluated. Now, this is another paper that was published in 2016, looking at 32 separate different clinics that had implemented OMSC. with almost 4,000 patients. And the focus within OMSC really is to try and implement a systematic approach to identify, document, advise, arrange follow-up, and make sure the pharmacotherapy is arranged. And you see that when OMSC is implemented, the proportion of patients that are asked about their smoking status, advised about their smoking habits, and then also acted upon, whether that's follow-up or counseling or medications, significantly. These are not relative risk increases. These are absolute risk, or absolute increases of 16%, 18%, and 19%. This is almost like a 50% relative risk or relative increase in terms of the proportion that are acted upon. Really impressive stuff, and just kind of going through a little bit in terms of some of the background data. What about the effectiveness? So those are just the numbers in terms of the ask, advise, and assist. What about the impact on actual smoking cessation rates? Well, when OMSC was implemented, and this is a meta-analysis of the first 9 hospitals that it was implemented, you see that the quit rates at 6 months are 18% at baseline and increased to 29% absolute. Again, that's like a 33% relative increase, if not even greater, and an odds ratio of 70 or increase of 70% compared to baseline. What about clinical outcomes? So this was a study that was led by Carrie when she was in training, and looked at the effectiveness. So what happens when people are given access to the OMSC approach versus if they're not, and combining it with the ICS database and looking at healthcare utilization at 30 days and then at 2 years. Really, some of the strongest evidence we have in terms of the model and the impact it has. So first, looking at 30-day utilization, you see significant reduction at 30 days when OMSC was implemented versus when it wasn't. You see all-cause readmission dropping by almost 50%, smoking-related readmission dropping by 40%, ER visits dropping by 22% amongst those that were given access or treated via the OMSC approach versus usual care. When we look at 2-year outcomes, it's even more impressive. And to be honest, when I first saw this and read this, I was like, this is too good to be true, frankly. Like, this seems like it's unbelievable. But what you see is that in terms of utilization and risk of death, even at 2 years, those that are given access to or treated via the OMSC approach and then subsequently are treated for their smoking issues and then hopefully quit, you see amongst those that there's a significant reduction in all-cause readmission, smoking-related readmissions, ER visits, and even death, right? So we don't have randomized controlled trials about smoking cessation and death in many cases. That it's hard to give cigarettes to people and not to others to identify the harms of smoking. We do have studies that are experimental, looking at the effects of an approach like OMSC or medications to try to help people quit and the impact that it has on important clinical outcomes. What about in terms of cost savings? Again, you see that the average cost for somebody who was smoking was about $26,000. And amongst those, and this is obviously the y-axis is a little bit adjusted in case you didn't notice that, but you see that there's a $4,000 reduction in terms of cost to the healthcare system when OMSC is implemented, when patients were within OMSC versus not. So you're saving money. And a lot of this evidence is the reason why OMSC is special. OMSC is one of the most special programs that exists. We are evergreen funded through the ministry's public health and prevention arm. That is what supports our work. We're considered to be so slam dunk that the ministry is putting money towards it on an annual basis, millions of dollars, to make sure that we're able to reach those that are in Ontario to help them quit, right? And that's why we have this team. We have this well-oiled machine that was founded by Andrew Pike, Bob Reed, and then supported by people like Carrie and Sophia. So, this is the background to what I walked in, and man, was I extremely fortunate. I thank my lucky stars for being in a team like this, because to join a team like this, now granted, there's a lot of operational work that needs to be done, and of course, research is an important component of operations, but just to have that foundation is just unbelievable, and the connections that one is able to make is tremendous. So my role since coming into the position, both in terms of chair and what have you, has been, well, how do we take this and take it to the next level? How do we incorporate innovations? How do we incorporate and evaluate new drugs? How do we take this global? How do we get this tested in China or India, where there's hundreds of millions of people smoking, not maybe certainly thanks to all the hard work that's been done by people before me, but the prevalence rates in Canada are much improved, although in some circumstances it's not the case, like in the First Nations communities where 50% of people still continue to smoke. But in general, the prevalence is about 10%, but it's like 30, 40, 50% in many other countries. How do we take our approach and adapt it to those other countries? Well, we're working on it. And hopefully the next time I present, we'll have some more information about some of these things. But this is something that was, and again, I could probably go on and spend the entire time talking about the fantastic background research that's been done related to smoking cessation and the OMSC program and beyond. This was actually probably one of the most interesting things that I have read in the last year as it relates to our program. And what this was is, this is an evaluation that's done by Ontario Health, Cancer Care Ontario. And what they did was they said, well, we've got lung screening programs. We want to see what happens if we pilot smoking cessation into these lung screening programs. Now, with lung cancer, as I'm sure many of us know, to get screened, you have to be a certain age, you have to have a certain history of smoking, and the majority of them, 80% of them, have a history of smoking or actively, in the process of smoking. And so a very important niche population of those that continue to smoke, of those 10%. And that's really one of our main focuses nowadays. How do we reach those individuals that continue to comprise that 10%? How do we avoid new smokers? How do we try to get these 10% that are smoking to stop smoking? Anyways, this is an opportunity to reach people that have been smoking probably for 50 years, 40 years, are getting lung cancer screening in their 60s. Except none of the actual programs that do smoking cessation were actively participants in this particular study. This was run entirely by Ontario Health and gives some degree of validity or external credibility to say, well, we didn't just fudge the data to meet whatever we wanted to push, right? So Bill Evans, who's the chair of that committee, was who led this. So there's 8,000 patients over several years, about 4,500 people that continued to smoke, that were smoking and were referred for smoking cessation, and about 3,000 accepted this. They randomized, or they not randomized, but they had sites that had OMSE, which was delivered by them. We kind of help support them. There are sites that had, which we were considered high intensity, and I'll take, we'll be happy to be considered high intensity. It's not high intensity for them, it's high intensity for us. But the middle approach being moderate intensity, and then the last one being low intensity, and comparing the effectiveness of smoking cessation between these programs. So as you may or may not know, there's a couple of major programs in Ontario. One is us, the other one is CAMH, big program, does fantastic work as well. They were included in this. They're one of the arms and we're one of the arms. So spoiler alert, our effectiveness rate at 1 year when they are implementing, not us, because I think our numbers are much better when we actually do this fully from start to finish. But when they implemented, you're looking at 20%. That was almost double the next best, or it was almost double what the other programs did in terms of effectiveness. They were like 10, 12%. We're at 20%. Now, if you remembering that we're looking at 12-month outcomes as opposed to the usual 6-month outcomes, which are usually better. And maybe that's why there's a difference, although we are working on this analysis as well. But the idea is that us compared to everybody else, increased mean number of quit attempts at 12 months, decrease in the number of cigarettes smoked per day, and decrease in the heaviness of smoking index, increase in the time to first cigarette. And you see these p-values are getting so long that they're almost falling off the sheet at this point. And we had nothing to do with this project or research program. This was all led by Ontario Health. This is the data itself, so I've kind of plugged in OMSE up there, and you see our rate of 20% versus 10.5% versus 13%, and looking at the total percent was about 15% quit rates. Now, you might think that we're satisfied with this, but I assure you our team is not satisfied with this, because number one, we don't believe these results because we've got better results, but also, even with our results, we're not satisfied because whereas somebody might see that as double as effective, I'll say 80% of people still smoked. And how do we help those 80%? What is going on with the non-responders? That's not a new concept. We deal with this all the time in cardiology. Why are those 80% not quitting? And in the other arms, why are 90% of people not quitting? These are people that, we hopefully have them engaged. They're coming to cancer screening programs. They should be quite scared and worried about what's going on. And there's multiple factors that I'm not going to get into today. But again, that's something for us to think about. So good news, but also bad news, why 80% of people are not quitting. So Beyond that, I think it's important to recognize that there's been a lot of work that goes into not just the counseling and follow-up and the NRT and the OMSE program, but also to think about, well, what policy levers exist and what impact they can have. And this is, we're going into territories where previous levers that existed are being removed, and we are somewhat worried about the impact that they'll have. And so just to give an example, in 2010, within the Champlain-Lynn, they added a performance obligation to the hospital accountability agreements for the 15 hospitals in our region, which said that they ensure the provision of OMSC to patients with the expectation that the intervention would be provided to 80% of inpatient people who smoke by March 31st, 2013. So it was a pretty it was a pretty important time frame to say by 2013 you have to have implemented. And the evaluation of this, again, led by Kerry, looking at the performance obligation to improve delivery of hospital-initiated smoking cessation interventions, a before and after evaluation. And you see what happens, like you're at 2010, and now all of a sudden between 2010 and, you've got the stable 3,000 people reached prior to the obligation. Then you've got this obligation period between 2010 and 2013. And you see during this time frame, there's a doubling in the number of people reached in our region. And even after that 2013 phase, there's maintenance of this. So, it highlights the importance of, we might be sitting here at the Heart Institute or wherever else people are sitting when they're listening to this, but the important thing to recognize, and this is one of the foundational aspects of OMSC, people working in silos are probably not going to be successful. You need institutional buy-in, you need infrastructure, you need to ensure that people are supported adequately. And obviously, there's nothing better than policy levers that can hopefully help in terms of reducing the outcomes or improving the outcomes as well. So a significant improvement. So you see that the number of people who were supported increased by a double. There's a pre and post change in the slope. It's like a 10% increase, so it's statistically significant. And so clearly this is important. However, in the past year or so, this has been removed. This lever that was there that has been removed. So it will be very interesting to see what impact this will have within our region in terms of our reach and our ability to help people quit smoking. Because again, like even though you can show people this data, obviously we're living in an environment where sometimes politics can take a little bit more of an emphasis compared to others. So this is looking at effectiveness as well. Now, again, you might not think it's much, but again, we're reaching more people and have higher effectiveness post-obligation. So 2% increase with the doubling, you're looking at a significant increase in terms of the impact that we're able to have. And again, you see the number of people that ended up quitting. It's more than double after the implementation of this. So again, the whole idea, and I apologize for the text here, but I mean, the idea is that for us to help avoid one hospitalization, OMSC needs to be admitted to or reach to 7 patients, and for one death is 14 patients. If you think of the number needed to treat for statins in primary prevention, we're talking hundreds here, right? So the impact that you can have here is tremendous. And we're reaching like 40,000 patients a year, so hopefully avoiding 5,000 hospitalizations per year and almost 3,000 deaths per year. This is another really interesting study that was done within the colorectal clinic at TOH, and actually several of these people who have now moved on to other centers are partnering with us to actually implement this program in London Health Sciences. So the surgical group is implementing their that's Terry Zwip, who's actually one of my classmates in med school. And then Joe Sadak, who's the first author on this particular paper, who's now at Humber River, they will also be going live. And we had a fantastic meeting with their administration. They're planning on doing an implementation where they're ready to go live in the entire hospital. And they seem to be very keen on rapid implementation of effective tools and services. So very excited about what's to come. But what this study did was, so taking a step back, so what this study is kind of trying to answer is, so right now, and in a different time, I might be talking about this particular topic, and I always harp on this, we need to treat smoking and smoking cessation, management and pharmacotherapy in the same way we manage any other cardiovascular risk factor. What does that mean? If I have a patient in clinic that's 19 years old with a blood pressure of 200, I don't let them leave the clinic without starting a medication and referring them to a specialist, right? That's common sense. But for some reason, and again, that would be very appropriate because these people are at very high risk. But for some reason, when it comes to smoking, which may have as much, if not higher risk than that person towards development of heart attack, stroke, and death, we ask them, hey, would you be open to going onto a medication? Would you be open to being referred to a doctor or a specialist relating to this? And I think we need a bit of a paradigm change if we want to get that last 10% and beyond going forward. And what does that mean? It should be an opt-out approach. So if you're smoking, we are going to prescribe you a medication that's going to help you quit, whatever that might be. There's several excellent first-line medications, whether that's combination nicotine therapy, whether that's varenicline. Now there's more evidence for cytosine. There's some evidence for e-cigarettes, bupropion, et cetera, whatever it may be. But we're going to start you on treatment. Well, if you have to opt out that I don't want treatment, and you have to opt out that I do not want a referral to a specialist team that's going to help me with this. So that's the idea here, is that you implement this. And what they found, and usually I summarize this a little bit better than I will be doing here, but what they found was that whereas previous to the implementation, the number of people that ended up being referred for follow-up was like 20% or something like that. After the implementation, it was something like 80% that were referred to follow-up, and 60% of them engaged in follow-up. Just think about that. So initially, there are only 20 to 25% of people getting referred, and of course, only a fraction of them continue in follow-up. But when you implement the opt-out model, you're looking at 80% and 60% or so are engaging in follow-up. And we know that those engaged in counseling, follow-up, and pharmacotherapy are almost 5 to 10 times more likely to be successful to quit. So we need more implementation of projects like this. And we have that coming. We have a pilot looking at like 5 or 6 sites where we're implementing auto-enroll. Every new site that we're hoping to implement going forward, hopefully will engage in auto-enroll because of the tremendous impact that this can hopefully have. I told you guys about some of our numbers, and I see Laura in the audience, and I thank her for the numbers, but also I apologize for the fact that they're not the most up-to-date numbers. But this is for a fiscal year from within the last year or two, and these are very similar to what we do pretty much each year. So of those that are referred to us, about 2/3 of them will engage with us. At 6 months, about 4,000 people or so quit. Our intention to treat quit rates are about 25%, and per protocol about 38, which means if somebody we can't reach, we assume they went back to smoking. But interestingly, even of those that we reach and they don't quit, of the whole sample, 72% of them are at least reducing, if nothing else. So really, we're seeing this on a day-to-day basis. And I've mentioned this before, we're reaching 20, 30,000 people a year. If you count nationally, we're reaching, 40,000 or so. Locally within Ontario, we're reaching about 20,000 people. So, it's massively impactful. It's ministry funded, thankfully, and hopefully that only increases, although with the cuts, you never know. But for now, at least, it's been several years where we've been able to continue. What about our QI and research? So now talking about what we're working on now, that's the past, right? So what a wonderful way to be set up for any new staff that's joining OMSC, like, just to think about the background of work and decades of research and PhDs and masters and lives that have gone, legacies that have been built based on this. So now this is where we're starting. This is our starting point. So what's next? Well, we've got big shoes to fill, and we're probably not going to fill those big shoes, but we're going to create other shoes. Maybe we're going to have heels, and maybe we're going to have running shoes, but we're going to come up with something different and new, and hopefully it'll be progress. We'll continue to push forward. So in terms of some of our initiatives, I did want to highlight, and again, there is so many of them that I honestly can't go into each of them. And if you'll see just in terms of the number of grants that we've been able to be fortunate to submit and receive, we have a lot of interesting work being done, which is only possible through the team that we have. So what are we doing? So I think everybody realizes not too long ago, we had the massive COVID pandemic. Well, as we did the impact on what happens with certain policies, well, what did COVID do for those that were patients? Did it affect our reach? What happened to the providers, all of us that are involved in providing patient care? How did that affect it? And at the system level, what happened in terms of the care? Well, we've got several manuscripts working on this particular area, doing a very deep dive in terms of the impact of COVID, and that hopefully at the next rounds that I'll present at some point, maybe the next year or two, we'll have that data to share with you. What about, we know about smoking, but we also know about e-cigarettes and cannabis. With the legalization of cannabis, there's been a massive increase in terms of usage, right? So, and amongst populations that are not the typical populations. Maybe they're just more open. Again, I don't claim to be an expert in that particular area, but we're noticing that there are changes, and we also know with e-cigarettes, now that has just been unbelievable in terms of the number of people that have started using e-cigarettes. And one of the things that, just to go off on a little bit of tangent, I'm sure some of those people that are in attendance that follow the Cochrane reviews and the vaping cessation e-cigarettes for smoking cessation will say, well, the Cochrane Review every year gets stronger and stronger in its certainty of evidence for saying e-cigarettes are a strong certainty of evidence to help you quit smoking. Yes, if you look at just the numbers, but as Javad and I were doing earlier on this weekend, or maybe last week, if you look at what they compare e-cigarettes to, well, who in this day and age, there's not too many clinicians here, but I mean, in this day and age, it would be impossible for somebody to just start a single patch and say, on your way, or just start short acting and say, okay, that's good enough for you. We always use combination therapy. You have short acting and long acting. Just like you would treat diabetes, you have long acting and short acting. In the same way, we should be treating with combination therapy for nicotine replacement therapy. The majority of the studies that compare e-cigarettes to nicotine replacement therapy compared to a single nicotine replacement therapy agent, that's not standard of care. So you can come up with a million studies that show e-cigarettes versus that, but your control group is weakened. And so we need to be a little bit mindful before we make very broad statements about the certainty of evidence, because it's not comparing like to like. Clinical practice does not use single nicotine replacement therapy. So that's a little bit of my tangent on the soapbox that I'm standing on, that we need to be we should be critically appraising the literature when it comes out and not just take it based on the assumptions that, or the conclusions that are being made. But what we do know is that e-cigarettes may be helpful for people that are smoking and to help them quit, right? So even if it's saying versus NRT, well, we know patch is still better than nothing, like placebo is still not great, like counseling by itself. And so clearly there is some evidence that they may be effective in helping you quit, but there's also evidence that when used in collaboration with cigarettes, without the intent to quit, that they increase your smoking rates by 50%. The mean cigarettes go from 20 to 30. Right. And so the idea is that we can't, this is not, often, even when somebody posted about this on Research Service on Twitter, and I posted about certain things, and I get a lot of comments from certain groups that I won't go into, but the question always comes out like, oh, are you into harm reduction or not? And it's like, man, it's not that simple. Like, I don't want anybody to smoke. I don't want anybody to vape. I don't want to eat chickens, my own self. I don't want to eat Snickers bars and stuff like that. Like, we should be trying to go for a healthier lifestyle. If it's up to me, do I think smoking is bad? Of course, smoking is bad. Is it as bad as e-cigarettes? Probably not, but I ideally don't want you on either, right? So I think the focus really should be that, yes, we should be doing harm reduction with the idea that the best harm reduction is actually not being on any substance, including pharmacotherapy, if you can avoid it, right? So eventually that's the goal and target for us. Anyways, again, a little bit of a side project. However, this is relevant because, as I said, we're seeing 20,000 plus patients a year. Well, if we have this massive registry of 500,000 patients, of which 50 to 100,000 have follow-up, and now we start adding the impact that these co-use of substances can happen, we can come up with some very impactful research. And so we've adjusted our forms to incorporate concurrent tobacco use, concurrent e-cigarette use, concurrent cannabis use. That'll be exciting. We talked about opt-out. We're piloting that in several sites. Excited to see the impact it'll have. That's implementation research. Now, I can't claim to be an implementation scientist. I say that first and foremost. I'm more into clinical trials, but we have a wonderful team of individuals that is able to do this and has shown success, including Dr. Mullen, of course, who's in the audience. And then another thing that we're extremely excited about is the long-term outcome. So we're doing a QI project to say, okay, well, we're seeing so many people every year. Well, do they like the program? Do they engage with it? Like, what did they think of it? And also, did they quit at 1 or 2 years? Like long term, what are the rates? Because we talked about 20% in this study at 1 year. We stop at 6 months and say, all right, on your way. Now, what we're doing is actually going back in the last couple of years and reaching out to anybody that got into follow-up within OMSC and surveying them with 10 simple questions. 10 sounds like a lot, but it's actually not that much. We're just asking, are you smoking? Are you vaping? Are you using cannabis? Did you like the program? Did you hate it? Would you refer it to a friend if they were smoking? And then some demographics that I think are important to better understand. Is our program truly for everybody? Does everybody within the ethnicity or socioeconomic status or gender, sex, et cetera, does everybody engage in the same way? Do they like it in the same way? Well, we don't have that data. We say that like we're not trying to, it's a systematic approach. Everybody comes in, they get funneled. However, we don't know what happens in these particular groups. And so what we're hoping to show with this long-term outcome is what happened to the rates of smoking cessation, program satisfaction, engagement, et cetera. And of course, they are welcome to re-engage with the program. If they finish and they're still smoking, come right back in. We can help you, so long as you weren't one of the people that absolutely despised us and don't want to engage. But even still, we will help you through that. So these are some of the initiatives that in and of themselves will have some very impactful results that are coming out, and expecting to share that within the coming year. Just focusing a little bit on the long-term outcomes a little bit, and I won't get into too much detail because it's in the midst of our evaluation at this time, but I'm just going to provide some very high level information about this particular project. So as we said, we joined OMSC within the last couple of years, so it's about 5,000 patients that are in follow-up, and what we're looking at is current smoking, vaping, and cannabis status, to see longer cessation rates, also satisfaction with OMSC, which includes those that might have just shown up once and said, I don't want to do telephone follow-up. This is not my style, like, or whatever it may be. And so we want to see the impact that types of follow-up have, and then also whether they'd be interested in re-engaging with the program. And so far, out of maybe 1,500 to 2,000 patients, we've got about 800 plus surveys completed. What's really amazing to see is that of those that were that completed the survey, almost half have they've continued to quit smoking, and so they've been abstinent. This is like 1 year plus outcomes that we're looking at, which is really impressive. But half of them have it's continued to smoke. Of those that continue to smoke, more than approximately 3/4 of them want to quit within the next 6 months. These are people who are interested and engaged. We just need to do better for them to help them quit. It's not like they're like, oh, I just don't even bother me. No, it's quite the opposite. Only 5% of people said they were not interested in quitting or cutting down. So you can imagine that actually, by us assuming, I don't want to broach this really sensitive topic with them. Actually, it seems like in a lot of our patients, they actually want you to broach the topic. They want you to offer them supports. They want you to give them something. And unless we ask these questions in a systematic manner, we'll never know. And the reality is that most of us, I had 25 patients yesterday. The reality is that you're working and you're not going to necessarily go through all of this stuff. And so there should be a systematic approach that helps anybody from the team that's looking after them to identify them, document their status, provide some brief advice. It doesn't have to be doctors, doesn't have to be nurses, could be pharmacists, could be respiratory therapists, could be a social worker, could be a physiotherapist, could be an occupational therapist, could be a peer support worker. This is not rocket science, right? The rocket science piece has been done. We need more people that can help others to quit smoking. All right. About a quarter of the individuals that were surveyed were using e-cigarettes. Now remember, these are often older individuals, and so this was quite surprising because the mean age is like 60. And so you're seeing that creeping in. But what was really interesting is about half of them are using cannabis. Like, that was quite surprising for me. Like, that's a large number that have used cannabis, and many of these, the majority of them were actually current users. In terms of outcomes, people will be happy to hear, actually, for what it's worth, and we will put the asterisk that this is for the respondents, so I can't speak to the non-respondents. So I don't want to do an intention to treat analysis on this one. But of those that had responded, the satisfaction is about 8.2 out of 10, with a median of a 9 out of 10 in terms of how satisfied they were with the program. And then also whether they would refer to other people, that's a mean of 8.7 and a median of a 10 out of 10, right? People like this program when they can actually get into it. The comments from those that didn't like it are going to inform our program and how we improve it. And there's going to be a lot, and we want there to be a lot, because if this activity is focused entirely on how to improve our program and going forward. All right, so that's some of the QI stuff. What about our research? So now there's a lot of projects that I've listed here that are at different levels, and some of them that are led by myself, some of them that are led by Carrie. So the first one on there actually is led by Carrie. It's a CIHR-funded randomized control trial looking at smoking cessation in the emergency department. So we talked about how do we increase our reach? Well, some people don't have a family doctor, don't have a cardiologist or some sort of access to healthcare system in a place that's OMSC enabled, we'll say that. The only exposure they have is the emergency departments, maybe paramedics, maybe the emerge. Well, this study is looking at initiating counseling and follow-up, as well as the pharmacotherapy right within the emerges and hopefully getting connected. So really, hopefully increasing our reach. Very interesting work, and really excited to see what the results of that will be. Randomized controlled trial. There's another one, which is a step 1 study. What we are doing is partnering with somebody within the industry specific to this, and they developed a smartphone application with a bunch of researchers. And this program is actually focused on trying to help people that are not interested in quitting, right? So some people are not interested in quitting within the next 30 days. Well, how do we get them to be ready now? This particular project in an observational study was able to move people from the not interested in quitting, 0% were interested in quitting, to 40% by 30 days. So significant increase. And of the population, 20% ended up quitting when they were given the app. And the way the app works is like, it starts off by saying, what do you love about smoking? Tell me about that. And then you're going through all of these things in the morning with content. And then in the afternoon, it gives you an activity to do. So really engaging patients at their time. You don't have to wait for a telephone call or a video call or a visit with me. The app itself can actually deliver some of this care. There are some interesting stuff that will come out of this, including collaborations with this industry partner for ongoing research in this area. And we were fortunate as one of the, I guess, people that had been involved in the BHI. This is one of the projects that we had submitted towards the BHI and received funding, approval for funding to support this randomized controlled trial, and then to take it to the next level, to then test it not just in those that are not interested in quitting, but also those that are interested in quitting. The implications of this are tremendous, obviously, in the context of the world we live in, to have apps. Most people have smartphones, most people use smartphone apps. So that was a CIHR funded study as well, the action grant. Then we've got vaping cessation. So, we're building a program in vaping cessation. We've got like, I probably can't even keep count, certainly not in one hand. So we've got like vaping cessation systematic review on abstinence, intention to quit. We've got a outpatient survey that was done on vaping rates in the Champlain region, inpatient vaping survey for those that were admitted to the Heart Institute to see what their rates are. Looking at, in terms of this particular study, which is a randomized controlled trial, randomizing people to usual care versus OMSE, which will incorporate nicotine replacement therapy. At this time, there's no large studies, more than like 20 studies or 20 patients or so, that are looking at nicotine replacement therapy for this indication, but it's an addiction to nicotine. And for some reason, it's not covered. So we had to go through Health Canada to get this approved and blah, blah, blah. Anyways, long story short, it has gotten thumbs up to use NRT through some innovative approaches. I'll leave it at that. But, we didn't have to do a full-on application. We were able to get this approved. And the idea is, just like we're going to do this, and this is going to be a rapid turnaround. I'm very confident. We're recruiting 200 patients. We've already got something like 400 eligible patients ready to kind of review, screen, and then not screen, but I mean, they already meet the screening criteria, but to reach out to, and if they're interested, randomize them. So we're hoping that this will be done within the year. And yeah, like the idea would be, well, how about exercise? Does exercise help people quit using e-cigarettes? What about varenicline? What about bupropion? What about cytosine? What about all the other things that we've talked about, right? So this is something that we're very keen and focused on, looking at that. Now, we also have a study looking at cytosine, which is one of the newer drugs, looking at patients who've relapsed. That's a randomized controlled trial that we're wrapping up at this time. ASAP, that's something that we're very keen and excited and proud of. I serve as the provincial lead for this multi-center CIHR-funded multi-million-dollar study looking at, well, so there's studies that have been done using varenicline for patients that are smoking. What about if we add nicotine replacement therapy on top of varenicline? Varenicline is the single best agent for smoking cessation. So again, if you want to like compare it to solo NRT, which again, I don't think that's fair. So it's equal in terms of its efficacy to combo NRT as a single agent. But what if you add nicotine replacement therapy on top of varenicline? Well, this study is looking at just that. Initially, it was focused to be planned to be an inpatient study only, now expanded to an outpatient study. We are leading this the entire province. We've done the CTO application. Hopefully, within the coming months or so, we'll be able to recruit relating to this as well. UHN, Toronto East, Trillium, Oakville, all the big centers, LHSC, et cetera. So lots of big centers in Ontario, and we're taking a leadership role related to this. Guidelines. So one of the other things that just to mention, so we were approved for the Canadian Cardiovascular Society guideline, which is, or not, sorry, scratch that, not guideline. That's a misstatement. It was a clinical practice update that we were approved for. And so I'll be chairing that alongside Dr. Mark Eisenberg, and several members of the OMSE team will be participating in that as well. And then we've got lots of different economic analyses. This is just a quick summary, and Javad kindly prepared some of these slides and looking at what we're hoping to showcase and demonstrate. This is a publication that we're very imminently, like literally within the next 2 days, going to be submitting. This would be the first meta-analysis of vaping cessation interventions. So systematic reviews or literature reviews have been done. This would be the first meta-analysis, including the systematic review, including the gray literature, et cetera, et cetera. And so what we know is that people are smoking, people are using e-cigarettes, but people who are using e-cigarettes are wanting to quit, and we have nothing to offer them other than saying, hey, just wean yourself off or whatever, off-label things. Well, what has been done in the literature, before we do a randomized controlled trial, we should probably figure out what all has been done. And that's kind of what we've showcased here. And when you look at this, there's been 7 randomized controlled trial arms, and you see that some sort of an intervention, now again, this could be education, this could be digital health, this could be pharmacotherapy. So we kind of combined it just to see what the results look like. And some sort of intervention seems like it's, got an odds ratio of 1.53 to help them quit at 7-day point prevalence within the first year. So moderate intensity. But then what happens in terms of 30-day? You see that, there's not a lot of data here. So recognizing the meta-analysis is not the strongest meta-analysis, but I think we put the flag down to say, well, we're going to update this every year as we publish new studies to inform this meta-analysis. And then similarly, in terms of continuous abstinence rates, it actually looks like it's significant. And this is combining behavioral therapy and as well as this one was looking at varenicline. So again, you see that there's a significant improvement with these various types of interventions. We also did subgroup analyses of what happens when you combine them all, but what if you spread them out? Like digital health is not the same as education. It's not the same as pharmacotherapy. And you see that the effect maintains, that there continues to be a significant improvement in terms of using digital health or, any of these interventions, even in and of themselves when you split them up. And hopefully we'll be sharing that systematic meta-analysis in the near future. Hopefully it'll be high impact based on some of the work that's gone into it. These are just some of the things that give you an idea as to where we're going. So, some of these things I've already mentioned, some of these things I have not mentioned, but these are some of the grants that we've received in the past year or so. So smartphone application, which is a step 1 app to help people quit smoking. That will be very exciting. We've got some additional funding from BHI as mentioned. Vaping cessation. At this point, we've got 3 grants looking at vaping as a whole. So one was a vaping survey grant from UHIMO, very thankful for that. And then we've got the Division of Cardiology Catalyst grant for 2 years, as well as the UHIMO Innovations Competition earlier this year for building this vaping cessation program. Cytosine, we had received Oracle funding in the past. We received, as Dr. Liu alluded to, we received a grant from the Canadian Cancer Society, which is a challenge grant for $525,000. And this particular project is over 3 years. And the aim is to try and improve smoking. So we talked about First Nations, 50% of individuals in First Nations are currently smoking. Well, how do we help those individuals or support them through this, and frankly also help ourselves by adapting our resources to meet the needs of that particular community, right? And so this particular study is a 3-year study looking at implementation of OMSC adapted with cultural sensitivities in Indigenous communities. And we have partnerships from hospitals and clinics in the Yukon, Northwest Territories, which will be going live very shortly. They're actually coming for a visit in June to get things finalized. Nunavut, North and PEI, Lennox Island has a clinic. And then in Ontario, we have fantastic partners, and we're hoping to expand our reach within those areas in the North Shore with Mama Singwe, and hopefully within the Ontario Health Team that's focused within Indigenous health. So it's, $500,000 may seem like a lot, but when you've got those ideas in mind, that money runs out pretty quickly. So we're obviously going to be looking for partnerships. We're going to be looking for other grants that can support this implementation, et cetera, et cetera. But we're very excited for this. We are so thankful for the partnerships that we have and really trying to do things the right way, in a good way, as Richard will often refer to, and Anne and Allison and Peter will know that we've just been like, okay, we want to make sure we're doing this. We want to do this the right way. We need to talk to everybody at the university, at the TOH, at the Heart Institute, at the institute where we're partnering at. So, make sure everybody that goes through this has done the necessary cultural sensitivity modules, et cetera, et cetera. So we're very excited about this, and we see a wonderful and fantastic opportunity here. We also have in discussions of finalizing this as well, which is, well, this is a unique one. It's an industry-funded, investigator-led project looking at implementation of smoking cessation. So, we have a partner, which is an insurance company, who has a massive pool of like 5 million people that are currently plan holders, and they would love for them to quit smoking. Well, we know that they would love them to quit smoking because it's less disability days, less sickness, less medications that they have to cover, less life insurance, et cetera, et cetera. So they were like, hey, why don't we partner and send patients your way, and let's see, if we can get them to quit. And we're like, yeah, absolutely. We're all definitely all down for innovation. Virtual counseling, virtual follow-up, virtual delivery of medications. And then Carrie and I were thinking like, well, we are scientists, so we should try to make this more, not just an implementation piece. Let's make this much more scientific. And so then we're like, what if we randomize them to OMSC, which is virtual follow-up and counseling, and the virtual delivery, and then change the drug that we give them. So we either randomize to nicotine replacement therapy, randomize to cytosine, randomize to varenicline. And that's where we're going forth at this time, and would provide some of the most initial research that has compared these three drugs to one another, and would be immediately landmark if we can actually get this done. And the industry partners actually happy with that. We spoke with the Ministry of Health. They were actually interested in this idea as well, and will be looking to potentially apply for a peer-reviewed funding as well. But just to say that we're also seeing, how do we expand our reach through virtual care? How do we expand our reach by reaching communities that we may not reach all that much? And that's what this particular slide shows. Then I've got Carrie's two unbelievably strong grants looking at the CIHR study we already described, almost $1 million. And then the Connect study, again, how do we increase our reach? Well, try to reach them when they're in the emerge. Or this is the precursor, I will say. So I almost refer to the Breathe study as Connect Part 2, and Carrie will get that. So the Connect study was the original, the OG. And the idea is to build hubs like OMSC across the country, not just in Ontario. How do we empower other people to do this? And I'm standing here, and Carrie really should come up here and present. But I mean, she was able to get $3.5 million to build these hubs across multiple provinces, and really will be some of the most impactful work. And some of them, this project is coming to an end in the coming 1 or 2 years, and have already gotten sustainability funding and working towards that to maintain it, just like we have sustainability funding through the Ministry of Health. So really exciting work that's being done to, again, increase our reach, because they're implementing the Ottawa model in their own settings. Where are we going? Well, these are some of the grants that we've submitted to date, and there will be more, I promise you, as many people in research services already know. We're very active in this particular area. And so what we've submitted, so you may remember that low dose screening study where we came out as quote unquote twice as effective as the next best program. Well, Ontario Health recognized that and said, hey, we should reach out to these guys and say, why don't we partner not just in lung cancer screening in those 3 sites? Why don't we partner in the new sites that are coming on board? And maybe, and then we're like, hey, why are we sticking to lung cancer only? Go into breast cancer screening, go into cervical screening, go into colorectal screening. And so this grant, which is almost 7 million, is now between Ontario, Newfoundland, and New Brunswick. And the aim will be to implement in those types of programs, including a couple of mobile health clinics that go up in the Niagara region as a bus and go into the clinics and actually reach communities that are remote, rural, don't get access as much. And also in the north, in Sudbury, there's another mobile health clinic that we've partnered with. So really, again, how do we increase our reach? Well, let's get to where the people are, right? We shouldn't just partner with those people that want to partner with us. We should partner with, big catchment funnels and hopefully increase our numbers thereafter. And then, of course, we're, for those that know, the other hat that I wear is virtual and digital care. And so we have a couple of projects that are hopefully going to be partnering with industry, members of the industry. And we're submitting this project looking at digitizing the OMSC program, not just the resources, but even the counseling, follow-up, data collection, management, analysis, visualization. From start to finish, create a software where the use case initially is OMSC, using AI with chatbots and avatars, and then take that to the next level where it doesn't have to just be OMSC or smoking cessation. Maybe some people at 3 o'clock in the morning want to talk to somebody that is a healthcare tool at 3 in the morning, right? About hypertension or something, or heart failure. Well, This tool hopefully will be enabled with all of those use cases. Well, I say all of them, some of these use cases as we get that background. We're very lucky in OMSC. As I said, we have got lots of data, fortunately. Now we need to go through the data and make sure it's clean and all that stuff, but we hope to leverage some of that data to develop these tools. And so we've submitted to the ORIF, which is the Ontario Research Fund, as well as the New Frontiers in Research Fund. Now, to be honest, even if we don't get it, the seed has been planted. We will do this. It's just a matter of time. And we will get the funding for this. It's just a matter of time. So we are working on this in the background and continue to work on this, whether or not these funding opportunities come through. So where are we heading in the future as I try to wrap up? So obviously we're looking at nicotine pouches, cytosine, comparing cytosine and varenicline, wide-scale delivery, virtual access. And what are we up to nowadays? Well, we do a lot of knowledge translation, as you can imagine. I probably do about 2 to 4 lectures a month in various rounds and clinics and what have you. We have the largest conference in Canada relating to smoking and vaping cessation, presenting at rounds in New Brunswick, Cancer Care Ontario, American College of Physicians, Ontario Association of General Surgeons. That actually led to a lot of opportunities for collaboration. So that was amazing. We presented virtually for a German conference. We had visitors from Singapore, and then we're actually working on a brand new initiative, which is a World No Tobacco Day Forum, where we're bringing clinicians, researchers, and policy and NGOs together to align in terms of our vision and strategy of how we want to engage the ministry and the federal government to try and bring them on our side when we have initiatives. That's happening here in Foodsinalis, May 31st. We're also developing national standards, and I'm serving as the chair of the technical committee, national standards on smoking cessation that would be hopefully implemented in healthcare settings and hopefully becomes an accreditation standard that says you need to implement an approach like OMSC in all healthcare settings. Very excited about that. The federal government's already funded it. We've already had like 4 meetings for this, another one I think coming later this week. Hopefully within 18 to 24 months, this will be finalized. And then, as mentioned, we've got the practice guideline. We have internally set a deadline of July so we can present at CCC in Vancouver. I think Dr. Burwash doesn't need to know that because I'm technically on echo call on the Thursday and Friday. But we are working very hard to try to have this done in advance of that so we can get this published and then presented at OMSC 2025. So a bit of a whirlwind tour of where we were, where we are, and where we want to go. And I welcome any questions you may have.
Questions, please. And so use the microphone. And, yeah, just fantastic, Hassan. This is really, sort of taking not only a local success, right? Now actually going global, and this is super exciting. And then so in terms of some of the innovation, both on the I think the knowledge translation side, on the ability to actually do randomized trials, which is super important, and the ability to actually sort of reach greater communities as well. So this is excellent. So maybe we could actually go for one of the questions. Yeah, but just as for sure follow up. So the question from online is how can we change the public perception that smoking of cannabis does not carry the same risk as smoking of cigarettes? And in fact, the what is it? The PM 2.5 generated from a joint is 3.5 times that of cigarette. So somebody actually really know what they're talking about there. So, but yet there is absolutely no public health messaging on this.
Yeah, no, I think it's a good question. What I tell people is if you inhale cannabis, if you inhale tobacco, if you inhale e-cigarettes, if you inhale pollution, you're going to have an increased risk of things like lung disease, heart disease, atherosclerotic disease. If the question is, have we compared randomization of cannabis to smoking and the impact that that has? We don't have that data. We don't really have a lot of long-term data about the harms of cannabis. Now, is cannabis as harmful as cigarettes? I don't think so. I think we are all in agreement that I don't think that that is true, and we should probably have that public perception corrected if that is a major issue. But I would implore all of us to say, well, we should not. So it's like the whole concept of harm reduction, like harm reduction eventually to cessation, right? Like abstinence is the optimal harm reduction, is to not do the thing at all. And so hopefully smoking cessation, if you can wean off the cannabis instead of consuming it, as smoke, maybe you can take it as an edible or something like that. But I would say inhalation of anything can be harmful for your lungs and your heart, and we would not recommend that. But certainly smoking is the most harmful thing you can be ingesting at this point amongst the usual suspects. And we would absolutely tell people to not smoke. I would say that people that use cannabis often mix tobacco in their cannabis joints as well. So, I don't claim to have expertise in a particular area, nor do I think a lot of people know all of these information. And until you open up all the joints and say, what is the actual particulate matter and makeup of these things, right? So it's a fair point. Yes, cannabis is unlikely to be as bad as smoking, but it's also not okay, in my opinion.
Great. Yeah. So thank you so much for this terrific talk. One of the things I was curious about are like, what are some of the key components of the Ottawa model? And then you had this app-based thing, and it sounded like maybe some motivational interviewing built into that, but I was wondering, what pieces of that are built into the app for the people that aren't sort of ready yet?
Yeah, so in terms of the Ottawa model, the key components are that you want to identify systematically somebody that may be smoking and document that. So it's not just in my little cardiology note, it's available to everybody. So identification, documentation, some sort of a strategic advice to say, hey, you probably should stop smoking. Then ideally initiation of pharmacotherapy, which is hopefully going to 10 times their success rates. And then lastly, arrange follow-up. The systematic reviews, the Cochrane reviews that have been done on smoking cessation show that if you don't follow up your patients for at least 4 weeks, there's no improvement relating to your counseling. They need a minimum of 4 weeks of follow-up. And so that is a key component. And within our follow-up system, it's 6 months. And so I would say those are the key tenets. With the app, and there's another question related to the app in terms of how people get it. Well, the idea is that you come across patients and they say, I'm smoking, and you know what, I'm not interested in quitting at this time. That doesn't mean they're never interested in quitting. As we said, we know data from previous studies that say, even though they may not be ready right now, they may be saying, oh, in 6 months or 12 months, I may be interested. Those individuals, we would give the app and try to move them from a pre-contemplative phase to a contemplative phase to the action phase, and hopefully move them forward. It is absolutely based on principle. The person and team that made it were behavioral scientists, PhDs, et cetera, that then eventually had their app procured. And we're partnering in terms of the testing of it in real world. And if it works, then that's something that we can offer to our patients as well.
Yeah, actually, I want to follow up because Jess is here, and that also relate, I guess, in terms of the brain-heart connection. A couple thinking. So one is that certainly, in terms of cannabis, certainly there is a lot of interaction, right? In terms of psychological aspect, right? So in terms of the brain function, certainly can actually expose, earlier in terms of underlying psychiatric illnesses. And also there is some, concern on long-term follow-up in terms of cerebral function, and which can be an issue, so long-term wise. But the question I have is that there's been, sort of previous linkages of conditions like depression, anxiety, in terms of addiction behavior, and so many of those aspects. And so I'm wondering whether there is any, sort of psychological profiling in terms of the particularly, the resistant type of patients, right? May actually have some underlying psychological profile that actually makes it difficult for them to quit, and there may be some genetic components as well. So is there any tailoring or strategies, to actually profile patients in terms of the underlying psychological substrate, and therefore, be able to actually tailor the treatment beyond just, sort of the standard behaviors?
Yeah, it's an excellent point. And one of the challenges is that before cannabis was legalized, we didn't have this information. And so now we're kind of catching up with retrospective studies, which have in and of themselves challenges, as you know, with confounding. One of the things I'll just mention within our program that we want to incorporate or / have started incorporating in the last year is to ask patients that we ask all these questions, but then we're starting to ask them about whether they would be interested in research. And shockingly, like majority, almost 100% of them are interested in research. Like it's like way, way higher than we initially thought. So the idea would be that if that is the case, that maybe on those particular demographics that we're able to pull out, we can do certain focused assessments and evaluations and can do some more precision work. But it's early days at this time. The long-term outcomes is one aspect of that, and to see if something like that was incorporated for every patient, the 20,000 patients that we have, instead of the handful of patients that get to follow up, would we be able to build a massive database and registry of these people that we can then send surveys and incentivize in positive ways? That's the goal. That's the vision that we've had for the next 3 to 5 years, is to build that population that we can survey and have some more information. So that, but we're at the infancy phase at this point. And hopefully we'll have support from the research services and others as we move forward with that.
Yeah, my question was that you mentioned the Ottawa model is more effective, you have 20% results. Now, from what I get from your presentation, is it all concentrated in the apps that you use, or are there other special features in the Ottawa model that is superior?
Yeah, excellent point. So what makes us different from everybody else? It's actually not the apps. The apps are just starting now, right? So up until this point, it's virtual telephone follow-up counseling, the counseling at the point of care, telephone follow-up 6 to 12 times in the 6 months, and then free nicotine replacement therapy that's offered with titration of that. Right? Whereas another program, without going into details, will ask you, because it was predominantly a research program, would get people to do a 1-hour survey with them and then give you free product with minimal follow-up, except for the study follow-up. So we're clinically focused, right? So we're trying to do counseling and follow-up for those purposes, not for data collection. And so a lot of people, the reality is, don't have the resources to do what we're doing, and we're very lucky to have the team that we have. So it's not the technical stuff. And if anything, I've been one to caution everybody to say, we're not jumping into VR and metaverse and all that stuff. As we look to go global in India, China, Pakistan, Africa, whatever, many of these places may not have the access to high-speed internet, but they will have access to a telephone. Telephone follow-up. Up in the north, we see patients in Nunavut. They have access to phones. They don't have access to internet as much, right? So the idea is that this will, I don't think our virtual telephone follow-up will disappear. We want to increase our offerings to reach a younger generation, a diverse generation, and make sure that we're getting more effectiveness and reach to maximize our impact.
Okay, thanks. Now, in the well, I think the AI that you want to take up is a very good idea too, because they can then use that to do their own inquiry for motivation. But just one question. Was there any study on this effect of this smoking or vaping things? What is the pressure cost? Does smoking result in dopamine increase or serotonin increase? Were there any study on this?
Yes, lots. So the predominant mechanism for smoking or nicotine in general is that it binds that alpha-4/2 receptor, results in the influx of neurotransmitters that results in the release of dopamine predominantly, and then some serotonin as well. That's the primary, that's why people love it, right? It causes that to feel that way. The drugs like verticillin and cytosine bind that receptor continuously, so you don't have these massive influxes. That's the mechanism through which they work.
No, this is a very interesting result.
Yeah, maybe we'll catch up after recognizing we're a little bit over time. I apologize for getting a little bit tangent inside,
But sorry, yeah, so obviously a lot of interest in this area. So thank you so much, and fantastic work. Keep up the excellent work. Looking forward to more updates. And also thanks so much for the team as well.
Absolutely.
It's really a great effort. And so thanks everybody for joining us. And so we'll have a session next week. And it's Dr. Fraser Rubens. Take care.